So traditional methods of minimal residual disease detection in myeloma, which is when we look for a very small amount of myeloma cells, maybe there's only a handful of cells left in the patient, is actually by counting cells. So the main thing that we do is multi-parameter flow cytometry. Essentially, we take a whole bunch of cells from patients' bone marrow and we tag them with all sorts of things that change color, for example, when we shoot a laser at them, based on what the outside of those cells look like. And then we run them through a machine. And then if we see cells that look like what we'd expect cancer cells to look like, we say that patient has X many cancer cells, or this proportion of cancer cells. We've advanced to more inference-based methods. So for example, a relatively new method is called adaptive clonoseq, where we sequence the DNA of the immunoglobulin region. So that's the part of the DNA which will make proteins to signal that that is a cancer cell, for example, if it matches the sequence that we'd expect the cancer cell to have. Now, cell-free DNA is an even further inference because we're no longer looking directly at the bone marrow cells. We're actually looking at the peripheral blood, which is all the blood that's circulating around our body, for any kind of hint that the cancer is there. So the method that we focus on is looking at mutations. You can imagine like a needle in a haystack. So traditionally, when we look for specific targets of a cancer, like the DNA matching that specific pattern, which we'd expect the protein to look like on the cell, it's only like one major area that we're looking at. But what we do is a little bit different. We first take the tumor cells at diagnosis, which the patient is getting anyway, and we get thousands of mutations from that data because we use whole genome. And now we have 10,000 targets that we could be looking for. We then take blood after a patient's been treated when we're monitoring them, and if we find those mutations in the blood, that's a way of inferring that there's still some cancer cells left. So the first main challenge is that we're not dealing with the tumor directly. So the tumor is all the way tucked in the bone marrow. But we don't want to go directly to the bone marrow because that's really invasive. I mean, you can imagine a huge needle coming in to the back of a patient's pelvis. It's a procedure that has to be done typically in a hospital with like a medium-sized team. And a patient, if they live far away from a center, they may not want to drive there. And also, I mean, it's painful. So let's say that this is something that we'd want to do every 3 months to monitor a patient. That's not really feasible. So the easy way is, oh, let's just take their blood like a normal blood draw. But then the technical challenge begins that, well, hey, this isn't a tumor. Maybe 1% or even less than 1% of all the DNA in the blood is even coming from the tumor because all of the organs of the body are shedding DNA into the bloodstream. And then even if we find mutations, how do we know that those mutations or those changes in the DNA, which would suggest to us that there's disease present, is even coming from the cancer? Because maybe it's just a random change that has nothing to do with the cancer, or what we'd call CHIP, clonal hematopoiesis of indeterminate potential, which is also very common in myeloma. But we're working to solve these challenges. First off, by applying really good mutation filtering techniques to the original mutation. So our method, we get the original mutations from the bone marrow at diagnosis, and then we track those mutations over time in the blood. And by looking at things, for example, like the quality of the DNA at that area, how much DNA was there, and also how long or short the DNA was in the blood that has those mutations, we can better filter if the mutation is a real or likely cancer-associated mutation or something random like CHIP, which isn't useful for our monitoring purposes. Our goal is that cell-free DNA MRD detection can be something that is regularly used in the clinic. For instance, maybe every 3 months, a patient can get their blood drawn. We can get a test score based on that, based on if they found those cancer-associated features, like mutations in the blood. And then the clinician can decide if they want to change up a patient's treatment strategy. Now, it's important that this is very early stage data. So before any of this could be done on a large scale, we'd need a clinical trial that would validate that this technology is improving patient outcomes. But the ultimate goal is that in our preliminary cohort of about 12 sites in Canada, we're working on a study. It's called the M4 study, multiple myeloma molecular monitoring. So about a dozen sites across Canada, we're doing the initial test. So we're giving patients this test and the other traditional tests. And then so far, preliminary results show good correlation with those tests and actually the ability to see even more positives in our method than those traditional tests. And the reason we think that is because we're able to capture all of the DNA in a tumor and not just the region directly where the needle's going in. And that's just a general limitation of traditional bone marrow aspirates, is we're pulling up cells, but we're only getting the cells around the area where the needle was. So let's say that there was another tumor clone that was on the other side of the pelvis. That might be missed. So right now, we're working out the quirks in our initial test set, and the goal is that ultimately there'll be a bigger study, and we'll see based on the results of that study if this is something that improves patient outcomes. And then this will be another test that clinicians can order for their patients that will be less invasive. So if a patient doesn't want a big needle, they can just get a normal blood draw, easier to access, so they won't have to drive into a large center. And ideally, once the whole bioinformatics or the analysis process is optimized, something that we could get to a patient very quickly, like within a matter of days. So there are many areas where I believe that we can improve this test. First and foremost is not looking only at mutations. So what's interesting is the DNA that we get in the blood, it's not the same amount of DNA everywhere. So let's say that I take the DNA and then I map it to where it falls in the genome, like which chromosome it falls on. I won't see the same amount. I'll see some areas with a lot of DNA and some areas with a little bit of DNA. And the reason is because the DNA that's protected by a nucleosome, which is this protein that the DNA wraps around in the blood, I end up seeing more of that because it's less degraded. There are less things trying to break it down. Now, what's the way that we can use this to improve MRD is there's places in the DNA which we know that the DNA has more or less nucleosomes, or those proteins protecting it, uniquely in myeloma and not in healthy samples. And that's done through another technology called ATAC-seq. But because we know those regions, we can look at those specific sites and see if we see a lot or a little bit of DNA to infer if the chromatin, which is the structure of the DNA with those proteins, resembled what we'd expect it to look like in myeloma. And on top of that, we can also look at things like copy number changes. So did the patient gain a chromosome arm, for example? And I think all of this data together, in addition to even other things like what does the DNA look like at the end of the fragments that we see, it's called end motifs, can help us build a more robust model to give us even greater accuracy when we're deciding if DNA from a patient's blood is likely coming from a multiple myeloma tumor or is just healthy DNA. I'm always happy to collaborate with other centers. So if you're watching this from a center and you'd be interested in learning more about our cell-free DNA technology, I'd be happy to get in touch. So please feel free to reach out.